Hello, and welcome to Navigating the Way for Seniors. My name is Tabitha Tripp, and I'm the owner of Tender Hearts Home Health Care. I am also a member of the Senior Resource Association Group, which is a group of professionals that have come together to provide answers to some of the questions and problems that our seniors face today. Today I have Kathy Heery with me. Kathy is a RN Geriatric Care Manager and owner of Healthcare Solutions for You. Hi, Kathy.
Hi, Tabitha. How are you?
I'm good. How are you?
I'm great.
Good. It's great to have you. And today our topic is going to be on what is going on in healthcare. So we're going to talk about some of the burdens and the cost of healthcare. And I was trying to do a little bit of research before the show, and I saw an article that said medical expenses are rising faster than the cost of any other service. They're climbing at rates that exceed not only those of inflation and dollar depreciation, but even the federal government itself. In fact, they are consuming an ever large share of personal and national incomes. Some 40 years ago, American medical spending was estimated at 5% of the national income. Today, it is calculated at 16.5% and rising. Why are the healthcare costs so expensive now, Kathy?
I know. I wish there was a simple answer, but I think we can frame it in a certain way. One is 40 years ago, if you look at when Medicare was enacted, it was enacted in 1965. So at that point, no one had health insurance over the age of 65. So it was put in to offset some of the rising expenses, the out-of-pocket expenses, but healthcare wasn't anywhere near expensive as it is today. Mm-hmm. Fast forward to 40 years, not only have we introduced more technology, but we take the technology and the treatments and the healthcare services and we apply a lot of healthcare to people. That's one reason. The second reason is we have a demographic and our populations are aging. And there's a couple of schools of thought, Tabitha, on that. One is that aging alone is a marker for healthcare cost increase, which I don't subscribe to. If you look at the boomer generation, which started turning 65 in January of 2011, that demographic or that cohort is different than the senior population today that's in their 80s and 90s. The boomer population is much more involved with their decisions. I mean, if you consider that the boomers brought in, had babysitters in their home, daycare, look at all of the services that started to promote outside of with decision-making and outsourcing that. The boomer cohort is much more involved in their decisions. So I don't think we're going to see the amount of health care that's given to people per capita stay the same as the population ages. So I have also looked at some of the economic studies that have been done, and it does show that the nature, which is the third reason, or the structure is a better word, of our healthcare system is probably the key driver of healthcare cost. And the reasons being is that anyone who's watching would have to guarantee, or has probably had the experience of having multiple tests done. You go to one doctor, they repeat the same test that you've had done at another doctor. Mm-hmm. Someone who's been hospitalized, the care, the services aren't connected, they aren't coordinated, so what happens, things get missed and they end up back in the hospital. And I have two clients that I see right now who have been in that cycle that we're looking to stabilize. So aging populations is one contributor. And the structure of our current healthcare system is a second contributor. And I guess the other thing, just to finish, would be the economic climate of our country. You know, we are in well, the economists say we're not in a recession, but, you know, for those of us who are living day to day, it's...
So some of the new technology that's out there, you know, all these little microscopic surgeries that they do now and all of the drugs that they use now, that just plays a small part in why it's so expensive. It doesn't
smaller
part.
Yeah, I think that it's easy to blame the fact that we have new technology and new drugs, and they are expensive, but we aren't all using them. If I were a person on a drug that cost me $15,000 a year, I'd say, yes, it's the cost of medication that's driving it. But essentially, it is the overutilization of services and the underutilization of other services. We need more of a focus on prevention and we need less of a focus on the intervention, especially at end of life.
Okay. I was also reading something else too, because I like to read up on topics. The number of Americans aged 65 and older is 35 million in 2000. By 2020, it's expected to be 54 million. People have more health issues now, of course, as they're growing older. Now they're in the hospital more. They're aging. They're using more prescriptions. So with all of that there, that's part of the aging population. That must be causing it to rise pretty quickly, the healthcare.
It again is the current level of healthcare services we have now tends to overutilize. People spend more time in the hospital. Hospitals are very expensive places to be. What's happening today with healthcare reform, the Affordable Care Act that was passed last year, is we're seeing a consistent and subtle shift of healthcare services out of institutions, hospitals, nursing homes, and into the community, where it is sometimes less expensive. It depends on the type of services you have.
Right.
But those of us who are in the industry now are coordinating or attempting to coordinate all of those services so people can remain in communities. So someone who might have been in the hospital for multiple comorbid problems today might be better managed in a community setting, say in 5 years from now, with all things being equal.
Okay. So what is the disagreement then in healthcare over medical cuts, Medicare cuts?
That gets into the political piece. Healthcare is very political, at least the public programs such as Medicare, Medicaid. I know there are a lot of private insurers, but the big nut where Medicare goes, others follow is true. So when Medicare makes a change, you see the other insurance companies following suit. And the overarching debate right now in Washington, if I could simplify it, is on the Republican side, the right side, they want much less government. On the Democratic, the left, they tend to favor bigger government. So how does that factor into Medicare, right? The Affordable Care Act and Medicare was passed under a Democratic Congress. And it's been up and down over the past 45 years with cuts. The Balanced Budget Act, for those of us who are in the industry back in the late 90s, really sliced and diced Medicare and scaled back services. And then it came back, only it came back a little bit differently. So as you know, we have a debt crisis. It's still not resolved as of today. And Medicare and Medicaid, both programs, Medicare is the federal program, which is the same in every state. Medicaid has some federal dollars, but it's essentially controlled by the state. In Massachusetts, Mass Health is the state Medicaid program. They're eaten up, to get at your opening statement, larger and larger portions of the GDP. So if you look at that 20% that they're projected, if we didn't do anything, that it would be in the next few years, that means one fifth of every dollar is consumed for health care. And if you look at the demographics sliding up, then you can see that trend continuing. And that's at the expense of everything else we can do. So right now, the debate is, how much are we going to continue to spend on Medicare the way it is? So the Affordable Care Act actually looked at that. And instead of continuing to pay doctors and hospitals and nurses and all of us that are in the healthcare industry for everything we do, it's slowly moving toward what's known as a bundled payment. So providers will have a certain, say $100, just to keep it simple, to provide services for you. If you were to have a hip replacement or something like that, there'd be a fixed fee that would be paid, and the providers would have to work together to manage your care in the least expensive way, but producing the highest quality service. That is so different than the way we do it now.
So is this all part of the Affordable Care Act?
Yes. The movement toward bundling and moving away from what's called the fee-for-service, where providers are paid for every service that they do, into this is part of it's being phased in. So next year, 2012, is a pinnacle year because the providers, hospitals, physicians, are moving into what are called accountable care organizations. Have you heard of that term?
No, not at all.
Well, ACOs is the acronym, and you hear that thrown around at all.
And
ACOs.
what is it again? Is it
Accountable care organizations. And when you're out talking to anybody, like physicians in hospitals especially, you can see them starting to reposition themselves. And what that means is groups of providers, physicians, hospitals, home care companies, rehab centers, SNFs, skilled nursing facilities, they're all going to band together to be able to provide the health care that we have along what's called a healthcare continuum, the continuum of care.
Mm-hmm.
Anyone who's been in the hospital knows that when you leave the hospital, everything gets dropped. Mm-hmm. Then you have to start all over again. When you come home, things
Right.
get dropped, and they give their information over and over and over again.
And that's where things start slipping through the cracks.
Exactly. Exactly. A big piece of accountable care organization is what's known as the electronic medical record. Right now, a lot of offices, hospitals, well, I shouldn't say hospitals had electronic systems for a while, but it's just for that particular facility. There'd be access to information for the patient as he or she crosses the continuum. So if I'm allergic to penicillin, then I wouldn't have to let them know when I go into the hospital, when I go into the rehab, when I come home again. That information follows me, and it stays accurate, reduces errors.
It's like in a pharmacy. They have all of everybody's records so they know what drug shouldn't be taken with another drug. And we find that a lot, too.
That's a good point. One of the things I recommend for people that I come in contact with is to please, most people are on more than 5 medications, is to obtain your medication from one source. Because the pharmacist is a wealth of information. I use them all the time. But also, too, they have the databases, so they can put in if a new med is ordered and
Right.
there's a potential, the synergies aren't right, one could potentiate the other or inactivate or otherwise, interact that's not healthy for the patient. It can be flagged and the physician can be notified.
So this continuum will help our seniors that have to go to the hospital and then to a rehab and then back into home, whether it's home health care that picks it up, and they'll know all about the client.
That's the goal. That's the goal. And that starts in 2012, accountable care organizations. These groups are applying now, and then they'll start in January 1st of 2012. Another thing in 2012 that's starting for the Affordable Care Act is going to be penalties for excessive rehospitalizations.
Oh.
And excessive are benchmarked against normal, whatever normal is. Sometimes it's state, but there were already studies that have gone on. There's groups that have worked on this that have come up with some wonderful methods and methodology. And there are simple things that we as providers can do, and patients and families can do to help avoid that. And anybody who's been in that, retractable, I come home, I don't get stabilized, I'm back in the hospital, I go in. The insurance doesn't always pay 100% when you have these events because there's only so much allowed in a certain period of time. And then they get, then they get hit with these excessive costs. So it benefits all of us that are in the industry.
This is
to
this
work.
is going to change healthcare as we know it today.
It's a pretty significant change.
It's a very significant change.
For
I don't know a
everybody.
lot about it, but just by talking to you, it just seems like this is really going to be a big change.
But in some ways it's good because it has people, the providers that were working in silos coming together to work for the benefit.
Oh, sure. Your seniors are definitely going to benefit in all of this.
I think so. I think so. The thing that I'm not 100% certain at is the Affordable Care Act, which was passed in March of 2010, which is a little over a year ago, is phased in over through now in 2020-24. So at different pieces. It's a piecemeal of like the legislature does. As we go through the 2012 elections, and as these pieces are phased in, there's always the opportunity to make changes. And the biggest wild card right now is what's going to happen with the federal deficit and the decisions and what we're looking at.
When all of this comes into place, is Medicare going to be the same for seniors? I mean, or is that going to change?
I think that's a good question. Medicare, as we know it, will stay the same.
Mm-hmm.
I'm pretty confident that there will be payment for hospitals and physicians. There will be a payment for medications. The question that we don't know, the answer to the question that we don't know, is how will the reimbursement change for providers? Because that seems to be where the energy is going. Not the seniors' benefit. Like for me, if I was on Medicare, would my benefit be cut? But if I'm seeing Dr. X and they cut Dr. X's benefit, will Dr. X be available to me? So it's really a fine line to straddle in terms of where the cuts are going to come in the insurance. For me, I would think that you're going to see people not in the hospital as much. We as providers of healthcare are going to have to work together to come up with ways that share information with the experts and keep people in their home, however home is defined, whether it is an assisted living, independent living, private home, with or without family. This is what we need to focus on. And as populations age, they have, they have other diseases, but people can live well. if think of someone with hypertension or high blood pressure. Many people walk around with high blood pressure. They're fully functional and they're well controlled, and yet that's considered a chronic illness.
Right.
So disease isn't the marker for infirmity. There's a way to live well with chronic illness, and that's what a lot of us are working on right now, is those programs.
Okay. Okay, what is all right, what's going to happen now that's going to make healthcare services better coordinated and better connected?
Well, I think that gets back to the accountable care organizations and the ACOs. Right now, if anybody has been, I'm going to use that house analogy because I think this helps to explain
the one you said to me earlier on the phone? Yeah. This was good. I understood it when you said it this way.
That, if healthcare were a house, or healthcare experience were a house, and, I hired and said, okay, I'm going to pay you, Mr. Electrician, for every outlet that you install. I'm going to pay you for every piece of pipe, Mr. Plumber, that you put up. I'm going to pay you, for Mr. Contractor, for every room that's sheetrocked. So if people are getting paid by the task, they're going to be very productive at doing that task, and they probably do it very, very well. But what are you going to be left with in the end? A non-functional house. So to move that to the patient experience, oftentimes people have doctors who do things very, very well, but they're paid to do more of what they do very, very well. So Dr. X may be ordering tests and procedures and CAT scans and blood and all of that, and gets it back and then makes a decision based on that, which is the right decision based on. Then you go to Dr. Y, who's doing the exact same thing and making a decision. And then you go to Dr. Z, and then maybe in there you get hospitalized, and through all of this, meds change, treatment plans change, and it's very siloed. So the patient experience of the house, each piece is done very well, but it's not functional. And that's what our health system is like now. So how do we coordinate that, to answer your question?
Yeah.
The accountable care and the primary care physician practices are shifting. And within those practices, they're more of a care manager, case manager model that is going to help coordinate care through the electronic medical record. So now when the blood tests and all of that are ordered and in, I can go on, if I'm look up and see what's going on, so I have someone coming in to see me. I have all that data and all that information at my fingertips. So therefore, I can make a better medical judgment, and then if I have to refer to an associate, say a cardiologist, a heart doctor, then I can share the information and the recommendations by that particular individual and come up with a cohesive plan. I know what my patients are taking.
Yeah.
For those of us who work in the community and work at home, we have access to this. I been working with a home care company that also is putting up a medical record that's accessible and shareable. This is what we need to do to coordinate. It's not just the care for the patient in terms of tasks, it's the information, which is huge.
Right, right. Does the doctor coordinate the care?
A lot of people think so.
When it comes to a lot of the healthcare expense?
The patient-centered medical home model, there's some in Massachusetts. It's been around for quite a while. It does a very good job on this, and it's actually taken place in some states. And it's moving into Massachusetts and will be more and more prevalent as we go through 12 and beyond. But right now, physicians aren't really paid in their defense. If I'm a primary care doctor and you're coming to see me for the first time, and you have 5 or 6, you have congestive heart failure, you have breathing problems, you have high blood pressure, maybe you have a skin problem, you just had a total knee done, there is no way in 30, 40 an hour that I can learn everything about you and come up with a plan and then coordinate it among all your orthopedic surgeon,
your other physicians.
You have home care at home, so you have people calling. Physicians are paid, for the office visit. So with some of these changing models, there's going to be more money to coordinate care. So that's going to help. But right now, don't assume it's being done.
Okay. Well, we have just a couple more minutes, so just wrapping things up, is there any last-minute thoughts that you have that you'd like the viewing audience to know about this?
I think have hope. There are a lot of wonderful providers, a lot of great people out there doing wonderful things. And nobody's working in a silo by choice. Everyone tries to work together. So if you find that something seems to be missing or you have something to say as a patient, speak up.
Well, thank you, Kathy. You certainly do know the topic.
Oh, well, thank you
a lot
for
more
having
than
me.
I do, and I did some research and I didn't understand it. So if I don't
It's
understand it, I can
confusing.
see how confusing it is
It
to the
is.
seniors.
It's very confusing.
But we're very fortunate to have people like you that do know it and that care about the seniors. So we just want to thank you so much for joining us today. If you have any questions and if you want to get in touch with Kathy after, you can call the number at the end of the screen. Thank you so much, and we will talk to you again. Thank you.
Thank you.